could average out about 3 from each. That's how I it's good. I wanted to get some about what you can do. We might get going. Okay, well, we might get going. As the number one time tyrant, I don't want to lose my reputation before the end of the day, and it is getting late in the day, and I know most of you, like I, have received a rather large dose of inspiration and input over the last 2 days. So this is the final plenary, and obviously we hope to, in our speakers and in the panel, draw together some of the macro and micro issues that we've been discussing over the last 2 days and think about how they can be addressed and are being addressed more effectively. So to begin the session, I'd like to call on Leonie Segal. Leonie holds the Foundation Chair in Health Economics and Social Policy at the University of South Australia and is involved in a research program concerned with improving the life chances of the most vulnerable members of our society. Leonie has an impressive record in research and across a range of issues and many insights to share with us today. Today, she's specifically tasked with exploring the role of economics in studies of rural and remote health. Thank you, Leonie.
Thank you for the opportunity of talking with you today. I must admit I prepared this sort of quite general title, and then I thought, because it gave me sort of a fair bit of scope to work out what I was going to talk about, and then it's like, okay, well, what of that can I encapsulate basically over 30 years of research in 20 minutes, so it's going to be a bit of a race through. So I think a lot of people perhaps don't really understand what economics is about. So economics is a discipline which is concerned with maximising wellbeing, knowing that resources are scarce. So choices have to be made. And the questions we need to answer are what to produce, what's the ideal mix of services and programs, how to produce it, what's the optimal mix of resource inputs, to whom to distribute, who should we be delivering services to, and how do we actually achieve that ideal, how do we actually get the incentives in the system that are actually going to push us in the right direction, rather than we tend to have incentives which often are perverse and shifted away from where we really need to go. And a core part is actually how do we fund our health system for equity and efficiency. The other thing economists tend to do is take a systems perspective and a very theory and logic driven approach, which means often we sort of come at things from a bit of a different angle. So in terms of what to produce, the sorts of activities involved in that are what we call priority setting, and I must admit that was a sort of a focus of my PhD about 15 years ago, and that was really looking at if we want to reduce the burden of diabetes, how do we do that? And looking across the whole spectrum from primary prevention, secondary screening, secondary prevention, tertiary prevention, across modalities. So rather than come from a vested perspective, it's really, okay, if I'm trying to represent the best for society, how do we identify what's the most cost-effective thing to do? And if you think about it, if it if we invest in things which have low benefit per unit of cost versus things which have high benefit per unit cost, we are in effect wasting resources and we will not maximise the health of the community. It's a really simple logic proposition. So that's given rise to cost effectiveness analysis, cost utility analysis. Utility is basically a concept developed by economists, which essentially is saying that we can represent as best we can quality of life, effectively sort of perceived well-being on a scale from 0 to 1, or in fact we go less than 0 where 0 is dead, less than 1 is sort of states worse than death, up to 1 which is full health. And there's certainly states worse than death, and you do find them in the survey work. In fact, I was just on a meeting on stroke, and, you know, whether it's sort of stroke, people with severe mental illness. I mean, when you think about it, anybody who is committing suicide has decided they're in a state that's worse than death. The other thing that economists perhaps try to do is a lot more comparative economic evaluation. So rather than just looking at a particular program, it's thinking about, well, how does that compare with some other way we might address that problem? The how to produce, as I said, it's often about the sort of the workforce, the competencies, the skill set, what modalities. So are we looking at a clinical intervention? Is that the best way to proceed? Individual clinician, medical model, multidisciplinary, adult health, plus social, public health, social marketing, education, subsidies, penalties. It's quite interesting. I mean, I don't actually brand myself as a health economist. I mean, while I run a health economics and social policy group, often health economists or health economics is thought about the economics of the health sector, whereas my interest is much more around the economics of health and wellbeing, however that might be achieved, which is sort of a much more thinking in a cross-sectoral way. The whom to distribute, economists have done a bit of work around, I mean, really basic principles. Horizontal equity is a concept which basically simply says equal access for equal needs. So people who have equal, have a certain health condition, that regardless of where they are, what their socioeconomic profile, how much power or influence they have, they should actually get access to equal health services. Vertical equity is basically saying those with greater needs should get greater access to services. We don't do that very well. Any studies, I know sort of for instance studies of the Better Access program of providing psychological services through care planning. Lo and behold, we find most of those services are going to the more advantaged in in the sort of well-off areas. In fact, we I think a long way from actually achieving our horizontal and vertical equity goals. And in terms of this meeting, clearly regional equity. So regardless of where you live, city, regional, inner, outer, rural, remote, high, low SES, disenfranchised, the more competent members of society, how do we ensure that everybody, regardless, has access to what they need? I mean, that's your sort of ideal, and that's really underpins the principle of Medicare. We don't want to see people accessing services on the basis of capacity to pay, their location or their power and influence. The other part of this question is how do we fund? How do we fund for equity and for efficiency? And we have a lot of, I think, really misinformation around the value of private health insurance or subsidising that, or that somehow or other that's saving government's money. In fact, every time the government supports private health insurance, it actually costs the community money. It in fact diverts resources away from the public sector, because you find that if there's more resources going into private, then they're competing away clinicians from public. So in fact, economists are absolutely unanimous that universal cover will promote equity and efficiency. Every community that's adopted that has found that they've actually been able to achieve better outcomes for less money. It's quite disturbing though that, I mean, basically when Medibank came in 75 under Gough Whitlam, was only after a double dissolution, and in fact the biggest opponents were the medical profession, and what we're still probably seeing in the States. So then I had this sort of issue, what am I going to cover in this talk? I do quite a wide range of work over my career: burden of disease, priority setting, economic evaluation, health workforce, looking at outcome measurement metrics, defining research question. That's actually what I spend a lot of my time doing. If I've got a a 3-year research project, I might spend the first 6 months, 9 months, 12 months really understanding my research question, because if you don't get that right, you'll never answer it. You need to understand your question, you need to understand the sort of causal pathway, what your problem really looks like. And I think a lot of people jump in thinking they know that, but not necessarily doing the really deep work to fully understand causal pathways. The other thing I've done quite a bit of work around is market failure, how we've got sort of massive distortions to our health service mix, which relates to our sort of mixed Commonwealth, state funding, and sort of some policy work, particularly around nutrition. And there's sort of, I've just got a few manuscripts which cover, a bit the sort of range of work I do, looking at the role of the patient in the health system, how health funding distorts the health service mix, bringing together economic evaluations, 245 economic evaluations, looking at there's one on economic evaluation of interventions for problem drinking. Do within family external effects make a difference? One of the issues when we do economic evaluation, we normally look at the outcomes for the primary target of that evaluation. But if you're dealing with a program that's going to affect family members, that's going to affect the wider society, if we don't capture those benefits, then those sort of programs will always look poorer value than those where the benefits are much tighter, and we're really poor at capturing wider benefits, and particularly in the mental health space where we tend to find the impacts go absolutely beyond the individual. We do a really poor job at identifying those. Some stuff on costs of training, looking at community response to child maltreatment from an economic perspective, the nutrition strategy, and some work on, I suppose, needs analysis. I've done quite a lot of work on that. But what I've decided to try to cover is, and partly coming out of, I've been basically revising this as I've sort of sat through the best part of 2 days and thinking about where the conversation was going. So I've actually got a small bit on single fund holding, as that came up yesterday, and I was going to make a comment then, but I wasn't able to, so I thought, right, I better do that now. A bit on how to understand the problem, and a bit of my workforce work on mental health and diabetes, and just a bit of an economic evaluation we did of getting better at basically a diabetes program in Far North Queensland. I do a lot of work in a lot of my work actually isn't location specific, but where it is, I'm doing quite a bit of work with Congress in Alice Springs, so there's quite a bit that is in remote areas. Single fund holding, what it is, it's basically a concept where you bring into one pool funding from Commonwealth, state, health, other agencies, across program areas, across programs, across portfolios, into the one fund holder, usually operating at a regional level. In theory, it should maximise efficiency, because what it does is provide the greatest opportunity for resources to shift. At the moment, for decades, people have been complaining about stuff gets locked into programs, into portfolios. It's really hard to move them to where they're needed. So the idea of single fund holding is that would sort of free up those barriers. And it also puts a lot of focus on the community coming up with their priorities, what do they want to spend their resources on. Also, in terms of equity across regions, there's been some really important work when, for instance, New South Wales moved to a needs-adjusted formula to fund their regions, and that was sort of, I suppose, hospitals and community health centres. At the time when they implemented that, they had some regions in terms of when they did some needs-adjusted capitation formula, with some areas were getting perhaps 40% more than they should, others getting 40% less over a 10-year period by moving over time, those areas that were more needy got more funds, and it's sort of really important to achieve equity. It can work when we think about why have we had success in the motor accident area, and part of it is you have motor accident insurers who have the capacity to, they both get the revenue in, and then they can spread that money across whatever sort of program is going to make sense. So they can put that money into prevention as well as sort of treatment. US Veterans Health Administration, single fund holder, did some fabulous work about a decade ago, really thinking about where should our resources be going, managed to then cover more veterans, improve their outcomes. They, for instance, set up lots of drug and alcohol centres, lots more primary care, so they were able to respond in a very basically evidence-based way. And it will radically alter the service mix. So Congress, it's not entirely a single fund holding model, so this is, they provide services for something a bit over 9,000 Indigenous people, or mostly Aboriginal people in and around Alice Springs. But what they do have a health service, they do chronic disease, health checks, etc., but they have a very large social and emotional wellbeing program. They have a public health directorate that does a lot of advocacy work. They do a lot of youth work. The Women's and Babies program has, for instance, a nurse home visiting. They do a lot of work in the early childhood space. They have a men's health that is very wide-ranging, men's shed and a whole range of things. And this is basically run by a community-controlled board. You get a very different look when you have that sort of... and they do bring in funds from all sorts of programs and they effectively broker them. But there are challenges, so vested interests. So there's a lot of people who sort of argue against single fund holding. It will radically change the clinical mix and it'll change where jobs are located. It won't suit everybody. Major challenges. How do you get the Commonwealth and state to put their funds into a fund holder, move away from their program-based funding? How are they going to announce the next sort of, major initiative into this particular program if all that's sort of decentralised, even though when they announce these initiatives often means something else has sort of fallen off the perch that was working perfectly well. And, are we really going to allow different regions to set distinct priorities? There's technical challenges in setting priorities and service planning. Scope, what sectors are to be in this? I mean, if we understand that a whole range of social factors affect health, do we pull that into the fund holding budget? Early childhood education, do we bring that into our fund holding budget? There's financial risks. How do we work out how we're going to pay? If we continue with the fee for service model, we can find actually the budget gets sort of overspent. So whereas under a salaried, you can sort of probably keep a bit more control over that. But there's different pluses and minuses with salaried or fee for service. How do we retain our Medicare principle? There's been a lot of work around, okay, is there a set of core services that every region would have to provide? Ensuring quality. Not a lot of difference to the issues today about how we ensure quality. And how do we skill up the community to actually participate and so that you get a genuine contribution from the community about what are their important needs. It's interesting in some of the Aboriginal communities where they have done a lot of work on understanding need. One of the things that comes up is the first priority is keeping our children safe. And that's as much a health issue as anything else. So the other thing that I think is very important is this whole problem conceptualisation for more effective and efficient solutions. So one of the things that I suppose in the last decade in particular I've been really thinking about, how do we close the health gap, particularly between marginalised and disenfranchised and the sort of mainstream. And my view is you need a deep understanding of the source of the problem, and where that's actually taken me is to focus on the family environment and the trauma load that sort of people both bring into the world and then sort of carry with them, and actually like a sort of snowball seem to attract trauma as they go. And in fact, I mean, the literature on this is becoming increasingly clear that trauma is toxic for the brain development, affects the trajectory of all aspects of the developing child and their life trajectory in terms of health, economic, social, and all these things then sort of compound and interact with each other. And the sort of trauma can be historic. I mean, we know it's sort of passed through generations, through sort of epigenetics and other sort of mechanisms. Current trauma, economic, social, things like dispossession, racism, family-based, and people with trauma histories are often then less able to really struggle to parent well their own children, not because that's what they want, but they're actually struggling with their own history. We've done some work in that space with a PhD student of mine, Jackie Amos, who's a senior child psychiatrist looking at these issues, and there's international literature led by people like Jack Shomkoff, who've been looking at this sort of role of trauma and what we need to do. Partly what we say is there's sort of a major intergenerational impact where histories of trauma result in abuse and neglect, the consequences then sort of entrap generations. So what we're sort of saying is we need to really focus on the child, the family environment as a sort of priority, so that we can try to push family, these sort of next generation, rather than being stuck in this sort of vicious cycle of child abuse and neglect, in physical and mental illness and all these things. Basically feed on each other. How do we sort of shift that family so that they can move into what's a sort of virtuous cycle where you get sort of positive outcomes, all reinforcing each other. And this is sort of similar. Basically what it's saying is you get these sort of early exposures, negative consequences, psychopathology in childhood adolescence, and we end up with a lot of mental illness. I mean, the developmental origins of mental illness would say if we got things right with families and children, we could probably substantially reduce our rates of mental illness. What I've got there in terms of the dollars need to go, it's probably inverse to where they actually go now, but this sort of work helps us understand what we need to be doing. If we look at, for instance, Commonwealth mental health payments, that big yellow band is disability support pensions, so half of Commonwealth support payments are going there. Something like what have we got here? Things like the Headspace, this tiny little red block, the Beyond Blue, a little purple block. This is what's happening now. State mental health payments, I've included child protection there, which I think is an outcome of poor mental health, which is the pale yellow. In terms of things like child and adolescent mental health service, that tiny sort of orange or bright red band there. So where services are needed is actually not where they're going. Health workforce, one of the things we've done here is looked at, for instance, diabetes. The challenge there was how do we conceptualise the problem in a way that's tractable but reflects on the complexity. What we then did was essentially set up this wheel where as we identify what type of diabetes does someone have, and then what are the complications. We add an extra layer, which is a sort of psychosocial, economic implications, both because that affects outcome and it affects the sort of workforce that we need to treat that. And then we sort of modelled that going forward, and what we find is if we compare our sort of current primary care team, where the GP is, say, this pale blue here, then under a biopsychosocial model that would be about a third what it is, whereas a lot of the things like your social worker should be substantially expanded because we've got so much sort of psychosocial stuff happening with this population. The same with psychologists needs to be expanded, and things like dietetics need to be substantial. There's hardly any dietetics in the team now. That obviously needs to be substantially expanded. So these give us totally different answers to where we should go. We've been looking at infant, child and adolescent mental health. We had a number of, again, how do we conceptualise need, using a whole range of data sources to do that, and then comparing it with existing services. What we were looking at is current psychological distress, high-level psychological distress, things like risk exposure. Most children with current psychological distress have lots of other rubbish going on in their families. We need to understand that. If we don't understand that, we're not going to put the right services in place. So again, we're going to have a biopsychosocial response to these issues. We also then looked at what's your sort of clinical care look like? What people do we need? So for instance, we're saying that with these families, we need psychosocial support. That's not a maybe if you can refer to someone who's actually got capacity. This is sort of core requirement for these sorts of children and families. And what our conclusion was that, for instance, we looked at South Australia. The Child and Adolescent Mental Health Service sees roughly 2% of children. Our needs analysis suggests it's probably 7% of children with high-level need. Current CAMS FTE is roughly 180. We think it needs to be more like 900. Current budget, about 24 million. We think it needs to be about 100 million. We are nowhere near providing the service for that group, and we wonder why we're not doing anything about disrupting disadvantage. Until we start doing something serious about mental health, until we do something serious about supporting families, we will never get there. So just finally, this is sort of, I suppose, the standard economic evaluation stuff we do, looking at a diabetes program in far north Queensland, about training individual health workers. We basically looked at costs and outcomes. The cost of this program was quite expensive, about $10,000 per participant. We looked at almost no change in mean haemoglobin A1C, some slight improvement. The top level is those with a haemoglobin A1C above 11.5%, so these were very, very unwell and poorly controlled people. Endpoint, the Indigenous health worker group had somewhat better outcomes there. But when we looked at disease progression, there was very little difference between the groups. A lot of people moving through to stage 4, so this is sort of advanced complications. So the program did very little to prevent that moving through. Hospitalisations, very little difference, some small difference in terms of our diabetes-related hospitalisations. Quality of life score, very little difference there. But it was a very expensive program relative to current costs. So in terms of cost effectiveness, very poor, something like $200,000 per QALY. Normally you want to be coming in at something less than about $40,000 per QALY. And yet often these are the sorts of programs where funding is these sort of chronic disease ones. So just to finish with sort of overarching themes that I'm sort of covering today. One of the roles of economics is to, one of the sort of mantras I use, that we're using policy-driven evidence to drive evidence-informed policy. Taking as a systems and logic-driven perspective, creative problem conceptualisation. If we don't conceptualise a problem correctly, we'll never get the best solution. We can do costing studies, cost effectiveness, burden of disease, workforce and services planning, looking at funding models. I think perhaps too much focus is on this sort of costing side and not enough on the broader, thinking about the sort of systems level stuff. I think it can be useful to engage economics early, help refine research question, contribute how best to answer that question, and then use economists in policy and practice translation. So thank you.
Thank you, Leonie, and thank you for combining a wonderful, rich amount of information into the time that you did. Now I'd like to ask you to welcome Claire Sparke. Claire is with the Australian Institute of Health Welfare, and today she's going to speak about patient experiences of coordination and continuity of care. Now, the little fun fact about Claire is that she is a true Canberran, which means that on most weekends she heads to Maruya. And I'm sure we will all agree that that is certainly a mark of true Canberran. But the other thing you might know, and I'm really excited to think, she plays the trumpet. So.
Thank you, and thanks for sticking around for the afternoon session, everybody. So I'm here to talk to you about a study that we've commissioned, and we're doing, called the Coordination of Healthcare Study. And I'm just going to give you a bit of information about the Institute first, for those of you that don't know. I'm sure quite a few of you do. But we're an independent national data agency in the health portfolio. We were established in 1987, and we're supported by enabling legislation to use specific data use and confidentiality provisions, which gives us access to a wide range of data. We've grown a lot over the years. Started off with 68 staff, and we've now got more than 400. Started from 13 reports a year to 180. So we provide regular statistics in all the domains that you can see there. In 2016, we absorbed the health performance and accountability functions from the National Health Performance Agency, which is where this study originated. So those are our strategic directions. Leaders in health and welfare data, drivers of data improvement, expert source evaluated analysis, and champions for open and accessible data, and trusted strategic partners. And this study really fits into particularly those first three. So I probably don't need to go through this slide given the audience. But why is coordination of healthcare important? Well, many Australians, as we know, experience fragmented care caused by disorganised or discontinuous flow of information, communication and communication and coordination between providers. And we think that understanding patient experiences and their perceptions of coordination is important for improvement. So as I already said, the study was commissioned under the National Health Performance Agency, which later transferred to the AHW. The National Health Performance Agency independently reported on a large number of indicators under the Performance and Accountability Framework that was agreed under the National Health Reform Agreement in 2011. Under that framework, there was a continuity indicator which was to be developed. So the National Health Performance Agency went and consulted with a number of experts, and there was feedback that they wanted to see more indicators on the reporting across the sectors between primary care and acute care. The ABS regularly run a patient experience survey, but it's only designed to report at the national and state and territory levels. And there's a general policy direction in most developed countries to look more at patient-centred care. This has flowed on to the new Australian Health Performance Framework, which was agreed recently, and there's a whole domain there now on continuity of care. So our study, the Coordination of Healthcare study, has two parts. The first part is the survey of healthcare, which was run in 2016 by the ABS, asking people about their experiences of healthcare, and I'll go into detail on that a bit later. And the next part is a data linkage component, which will link MBS, PBS, including our PBS data, and hospital data from every state and territory around admissions, but also emergency department data. The study's objective is to fill an important information gap relating to patient experiences with continuity and coordination of care, and to provide contextual and locally relevant information to primary health networks. This study is sampled at the primary health network level, so we can report by primary health network on all the data that we have. The hope is that primary health networks will be able to use the information so patients can get better experiences with coordination of care, and GPs will be better placed to provide care to patients that's subsidised through the MBS and the PBS, and potentially fewer patients going to the emergency department. We'll be able to analyse indicators of healthcare in local areas on themes around access to care, patient-centred care, and information sharing amongst healthcare providers, and also look at certain population groups of people with chronic conditions and people who've been admitted to hospital. So it's fairly complex once you try and get all those data sources together. So this is the governance structure of the study. It was approved by the Department of Health Research Ethics Committee in August 2015, and the survey of healthcare was run in 2016. We also have had to go back and forth a number of times, as anyone who's done a data linkage study would know, to various committees. The Department of Health, the DRAP Committee, and the Department of Human Services External Request Evaluation Committee. We are going through a process now of talking to all the states and territories, data linkage units, data custodians, getting ethics approval in every individual state and territory. And we have a number of internal sort of governance structures as well. Doing this linkage will allow us to sort of look at participants' responses and their actual health service use 12 to 24 months before they were surveyed, and also 12 to 24 months after they were surveyed. The linkage to the MBS and PBS is somewhat less complex because we use the Medicare database to sample the survey, and we have consent from patients to link using that database. But the hospital linkage is much more complex in that it involves every state and territory and all of those ethics committees that I just talked about, and trying to get a consistent data format across the states and territories can be difficult. We hold the National Hospital Minimum Database at the AHW, so we are negotiating getting the data out of that in a consistent format instead of having to go to every state and territory individually, which is a plus of it being at the AHW. Okay, so we haven't done the data linkage yet, where the ABS are currently just merged the MBS data, and we'll be putting out a report with them towards the end of the year. But we have done some analysis on the survey, so I'm just going to go into the survey of healthcare now. So it was a paper-based mail-out survey, voluntary self-report of patients who are 45 years or over and had had at least one GP visit in the year before they were sampled. We oversampled what we termed high users, so people with 12 or more visits, which was about half of the sample, and in comparison, in the general population, about 25% of the people have 12 or more visits a year. It was stratified by age group, sex, PHN, socioeconomic status, and, as I said, number of GPs. And it's been weighted by the ABS to be representative of the population. So the survey asked a number of things. It asked about the way people used healthcare, waiting times for GPs, after-hour services, those lots of things about GPs, length of relationship with the GPs, whether they had a usual GP or usual place of care. It asked about use of specialists, whether they were seen, could get in, waiting times, etc., and information transfer back to GPs. Medications, whether medications had been reviewed and what went wrong if they didn't. Tests and x-rays and scans, whether somebody had been referred, could they go, did they have to wait. Emergency department attendance, hospital admissions, emotional and psychological health, and long-term health conditions, amongst other things. So that's the demographics of the sample by remoteness areas. There was about half were from outside of major cities. And so we had 29% from inter-regional areas, 15% from outer regional areas, and 4% from remote and very remote areas. Most people assess their health as good or very good or excellent. The age distribution was similar for all the regions, and major cities had the highest non-English speaking respondents, as we would expect, and also the highest rate of a bachelor degree. The most common educational attainment was year 11 or below, which is not surprising given the age group is 45 or over. So we released some data, which is on our website, so I'll give you a snapshot here, but if you want to see more, you can go to our website and have a look at it. This is about information sharing between this is whether people had usual GPs or a usual place of care. And as you can see, the usual GP, I've gone too far, sorry. I need to get back. Oh, there we go. The usual GP, people having a usual GP decreased with remoteness, as did having a usual place of care. We've looked at, as I said, information sharing between general practitioners and other services. And here's, again, as you can see, as remoteness increased, people reported that their usual GP or usual place of care didn't seem informed of what had happened in the ED, the hospital, or at a specialist more than in major cities. Just looking a bit closer at the emergency department, you can see, as I said, that information sharing decreased with remoteness. But there's an interesting finding there as well, that people in remote and very remote areas reported not having any follow-up needs more than people in other areas, so 14% compared to 6%, between 6 and 7% in other areas, so we're not quite sure what's going on there. When we link this to hospital data, we'll be able to see why they went to the emergency department around the time that the survey was done, so that we might be able to get some insights into that then. We asked about barriers to accessing GPs, and about 25% of the cohort in all areas reported that they didn't see a GP when they needed to. As you can see, as you would expect, by remoteness, the reasons for not seeing a GP when needed increased were due to no GP nearby increased, and the cost decreased, which is across all these barrier questions, which we're not quite sure why. Grateful if anyone had any insights into that. It's perhaps more pronounced in the next one, the cost as a reason why a barrier to seeing a specialist. No specialist nearby was very high in remote and very remote areas, as was unable to get an appointment across the board. And cost was a major barrier in cities. Barriers to access for tests, x-rays and scans was again quite high, no facility nearby in very remote areas, and cost increased this time as we went into regional areas, but dropped off for remote and very remote. I must note all of these, they could tick more than one, so they could have ticked all three if they wanted to. Seeing a health professional for psychological and emotional health. Again, cost was a big barrier in major cities and dropped off with remoteness and no service, but something that came up here was embarrassment, and it was similar across areas. And for physical health, service availability in rural and remote and very remote areas again, but cost was the most common one for other areas. We asked patients about whether they had visited an emergency department in that time, and visiting the emergency department increased with remoteness, and we're going to be we really want to know why they went to the emergency department. When we asked them why, this is what they said. The first two, you would hope that you would go to an emergency department if you had a life-threatening condition or you were told to. But again, waiting times and GP not available were quite high, as in very remote areas. So this is a large program of work for us. We are going to be putting out PHN level results in July on GP experiences, and that will be on the My Healthy Communities website, which has a lot of local level information at PHN or lower SA3, SA4 if we're able to do that for all the work that we put out there. And later in the year, hopefully towards the end of the year, we'll be putting out another report on experiences with information transfer in detail, and then a further report next year on access to healthcare, which by then we'll have linked data for, along with the report with the ABS later in the year, looking at the survey across MBS usage measures. Thank you.
Thank you, Claire. And now for our final panel of the day. Some of our panellists will need no or not much introduction, but we're looking forward to a stimulating discussion with the headline of the future research and the future rural health workforce. So if I could invite to the stage Amanda Kenny. Amanda is the Professor of Rural and Regional Nursing at La Trobe Health School, and the fun fact on Amanda is that she's a new grandmother, and also she's dying, like many of us, to see if we could dip out and get to the Cartier exhibition, which would be very... anyway, just have a seat. Dave Hallinan, welcome Dave. Dave is the first Assistant Secretary of the Health Workforce Division of the Department of Health, and he's a not very secret ACT Brumbies fan. Can I welcome Chris Bourke, who's the Strategic Programs Director of the Australian Healthcare and Hospitals Association, Australia's first Indigenous dentist. And we're very excited to celebrate with Chris, who got his MBA from Tom Karma on Tuesday. So congratulations, Chris. And finally, but not least, Rob Curry. Rob is a wannabe farmer. In his day job, he's, in his honorary capacity, he's president of the SARA, the Services for Rural and Remote Allied Health, but he is a wannabe farmer, and he rolled his tractor recently with the consequence of severe emotional trauma and consequences.
It's much better when I change for shorts.
Yes. All right. So, thank you, colleagues. What I'd ask is that I'm going to ask each of you what you would suggest are the most important areas of workforce research necessary, and I'm wanting you to think in 2018 and start to think forward about what are the gaps and what are the necessities of what we need to do and we need to be looking at if we're going to have a solid rural workforce policy to the future. So what is it that you, as a practitioner with a particular constituency and either a policy or a particular discipline or a particular perspective, that you think are the most important areas of workforce research, thinking forward from this conference? So Amanda, is it all right to start with you since you're on the end? If you're happy to grab a microphone and have a think about that?
I am. I think that's a great question, and I'll probably talk about my own discipline of nursing for a moment. And I think one of the things about nursing is that we still don't have really good longitudinal workforce data. I had an experience recently where I was talking to a senior politician, and he made the point that in nursing we have 10.1 nurses per 1,000 population in metropolitan, and exactly the same in rural. And so his point was, what's the issue? But of course, bringing it down to just 10.1 nurses per 1,000 population doesn't take into account geographic difference. It doesn't take into account the complexity of client need. And it also doesn't, take into account that I don't think we've done really good workforce planning, working out what sort of nurse we need in these communities. So a lot of the work that's been done, particularly in nursing, is just based on these numbers of nurses we need rather than the types, but also not looking at how we relate the workforce that we need in a community to client need and the types of health professionals that you need in those communities. I think the other thing is, I think we need to start looking at much more innovative models that are not just about traditional workforce models. I think there's some fantastic things that are happening in rural, but often we hear about the dire problems or the misery rather than trying to capture some of the small projects that have been done and working out how we can scale those, how we can develop some of those great small projects rather than taking years and years and years to actually get into practice. The last thing, I've got a good example at the moment. So we did some work 7 or 8 years ago on paid employment models for students. Actually, so I'm from Victoria, and we're only now doing a pilot of that 7 years later, yet all of that research was done that long ago. So it's about sort of how do we get research quickly into practice, how do we look at impact, and how do we get this knowledge translation happening in a really fast way, and capturing some of the really small stuff that's done and working out how we can scale that to different settings.
So Rob, do you want to think about that with your Sarah hat on, but feel free to stray further away from that if you wish.
Thanks, Jenny May. Look, allied health's quite different, I think, and we need to just briefly summarise that. So we have a really diminishing allied health workforce as you go remote. Everyone knows that. Roughly I'm a physio, roughly about a third or a quarter of the rate per capita in remote areas compared to city areas. I fully take your point about nursing, and even though you have equivalent numbers in remote areas, you are the backbone of the state health systems. Allied health has no serious funding mechanism to prop up allied health workforce in especially remote areas. We have market failure for private practice or private businesses. The gaps are obvious. We don't have a Medicare system essentially to support that workforce. So we definitely need a whole range of areas of research to make the case for allied health and to explain how it is needed. And that starts with data. We have very limited data for allied health, much better for the registered professions and much poorer for the unregulated professions or the self-regulated professions. We need to, as a fundamental point, start with the data, get good data, and that forms the basis for reasonable research. I've got a million other things to say.
Yeah, well, have a go. Scope of practice?
So really, we need to make arguments to the fund holders, to ministers, to employers about what is the efficacy of allied health in the different professions. What difference do we make clinically and through our programs? More than that, when we're able to do that, because we haven't been all that good at that, there's been work occurring over the past several decades to make to explain the efficacy. But I think we also need to translate that efficacy into cost benefit, the value for money of investing in allied health services. So if you're a health minister, why would I invest in allied health in rural remote areas, in Tennant Creek, where there's virtually none? Why would I invest in allied health? And we have to make that case. So I was interested in the health economics session before because we don't really understand the lingo, really, and we really need to understand health economics in order to translate our efficacy into a business case to be made for employers. Does that make sense? Sorry about that. I want to put a pitch for cultural safety. We want allied health professionals to be culturally safe in all contexts. The evidence around cultural safe practice is we don't have clear agreement on what cultural safety and security is, and we don't have a lot of evidence around its impact and its benefit. We all, as a matter of common sense, understand that it's critical, but we need to put some evidence, some serious research around why we would have culturally safe services. A pitch for Aboriginal health workers, we're silly, we are not supporting, you can't have cultural safety without Aboriginal people in the workforce. It's not fully achievable. You need more Aboriginal faces in the workforce. We need Aboriginal doctors, allied health professionals, nurses, of course, but if you live in a remote area, your best avenue, the most accessible avenue into the workforce for an Aboriginal person is through the Aboriginal health workforce, Aboriginal health worker profession, either as a standalone profession or as a stepping stone to other things. I just wanted to make that pitch. As a remote physiotherapist in the top end, I could not have done my work as a physiotherapist in remote communities without the health workers. I wouldn't have had a clue. So I just want to make that pitch. Many other things to say, we might come back to those. I better shut up now.
No? Chris, I think that's a perfect segue.
Thank you, Jenny. And of course, better engagement with an Aboriginal and Torres Strait Islander health workforce is, I think, the key to a better remote and rural workforce in this country. I think when you consider that, and I'll talk about nurses a bit, and congratulations to nurses for incorporating cultural safety within your code of practice recently, and well done to you for doing that. But when we consider that there's over 6,000 Aboriginal and Torres Strait Islander people registered as nurses in this country, and a third of them are unemployed, we need to be starting to ask, why is that so? And that kind of research needs to be driven by our research institutions engaging with Aboriginal and Torres Strait Islander researchers in a manner which is not just culturally safe, but free from institutional racism, which is another concept you've probably heard me talking about yesterday. Institutional racism is not the interpersonal behaviour of people who work in a particular health service. Let's be very clear about that. This is not about interpersonal relationships. It's not about the way people behave. It's not about how they treat Aboriginal and Torres Strait Islander people, patients or co-workers. Institutional racism is about the way an organisation or institution is managed, established, funded, governed, its accountability, its policies that produce poorer health outcomes for some racial groups. And in Australian evidence for that we heard this morning in the rate of kidney transplants and end-stage renal disease. And we can see it right across the board in cardiovascular disease. I think of all the, for instance, the AHRW report on waiting lists for non-elective procedures. The only procedure that Aboriginal and Torres Strait Islander people did not have a longer waiting list than non-Aboriginal people for was varicose veins. How can this be? But it's about that level of institutional racism. Now, some work has already been done about that. There's a matrix that's been produced in Queensland that people may be aware of. We at Australian Healthcare and Hospitals Association are working with the Maoris to develop that matrix. It's about incorporating Aboriginal accountability within the governance of an institution, within the professional management of an institution, within the workforce of an institution, and with its accountability. But let's not just think about hospitals and healthcare organisations. Let's turn the mirror on ourselves and look at our own organisations, whether it's an academic institution or an NGO. Do we, as organisations, are we institutionally racist at our organisations? Something for us to start thinking about. But to come back to that particular workforce question about recruitment, which is another piece of work that we're involved in, is that there's quite a bit of work that's been done internationally around diversity management about how to recruit people from particular groups. And the translation of that evidence into the Australian situation could be very beneficial for those organisations who want to recruit more Aboriginal and Torres Strait Islander people into their health workforce. And it's simply about looking at the recruitment process in a different way. Using organisational impression management theory combined with what we know that works in diversity management to come up with some fairly concrete operational ideas. I'm a dentist, I like that sort of stuff, about how particular tactics can be used to recruit Aboriginal and Torres Strait Islander people. For instance, sending strong messages of dependency in your recruitment messaging, telling people that you need them to do the job. Not that you're doing them a favour by giving them a job, not that your strategy is there to close the gap in Aboriginal employment, which the Commonwealth has used for many years but is starting to get over, I think. And as a result of that, you create an idea in that person that you, for instance, need me to do the job and that it is me that can only do this job for you. That creation of a level of dependence is particularly important for Aboriginal and Torres Strait Islander health workforce. But I'll stop there and move on to the Commonwealth. Thank you.
Okay, so I run the Health Workforce Division in the Commonwealth Department of Health. I guess probably the best way to start is to say the Department of Health, we've got a mission statement and it's words to the effect of trying to achieve better health for all Australians. And that's a good starting point because I think it does inform and influence how we operate as a department and how governments try to prioritise expenditure. I'll just expand on that mission statement a little bit and add some words that we would think about in the Health Workforce Division, and you'd probably say better health for all Australians no matter where you live, because my world, we're very interested in access to services and improving health outcomes for people everywhere, and that includes different population groups, rural and remote Australia, all those sorts of things. In fact, the vast bulk of my work is about rural and remote access through one form or another. In terms of research priorities, there could be any number, and it's a difficult thing for me to say what the best one is, because there's you've heard a lot already, and there's a lot out there. But I wrote a list outside, and I'm fairly agnostic as to what the best options are. You could consider models of care that provide better outreach services for communities that don't have appropriate access, or where there's a market failure, where there's not enough money in the system to support permanency. Better use of technologies in remote service delivery. What can we use to provide better services for patients in rural and remote locations that your smartphone might be able to do things that we haven't done before? Using different workforce models. So generalism is the theme of the day at the moment. I think it's been the theme for quite some time, but it's not just medicine, it's outside of medicine, it's nursing, allied health, other health services. And not just in the health setting. So where you've got small towns, communities where we do have market financing failures, where there isn't enough money in any particular stream of government financing to sustain full-time employment, are there models that could draw on the NDIS or aged care as well as health service funding? Are there models like that out there, and what can we do to identify them and promote them? And more than that, we've spent a lot of money and a lot of time on training and workforce retention models. So what are the best ways to train our workforce for rural and remote service delivery, and what are the best ways to retain that workforce? And what sort of research you conduct. I think this was something we discussed earlier. It really does depend on what it is that you're looking at, but fundamentally, if you're after financing streams and changes in government financing arrangements, I think we touched on economics, cost-benefit analysis, cost-effectiveness analysis, cost-utility analysis. So in a past life, in my current life, I passed myself off as a poor quality economist. And I worked in the Department of Finance for 5 years, doing cabinet briefings on a whole range of portfolio matters not related to the health department, but briefings about who was going to get money, how and why, what priorities would the government choose. The lens I applied in that role was one of cost-benefit analysis. So, it was cost-benefit, cost-utility, cost-effectiveness, or cost minimisation, depending on the particular issue. What is it that you're trying to achieve, and what's the best way to achieve it? In health, we tend to fall to cost-utility analysis because it's a good way to compare community benefit with cost across a whole range of different forms of spending. It's a pretty complex beast, the health system. It's 1/10 of the economy, and you're comparing interventions in workforce with interventions in pharmacy with interventions in other activities. So I would stress that in a competition of scarce resources, cost effectiveness analysis is a really useful thing to consider, and that will be a long-term, and I think it has been a long-term feature of health system financing. The pharmaceutical benefits scheme has run that way for a very long time. Health technology assessment processes, the really big financing mechanisms in the health system run that way, and I would encourage people to think about things through that lens to the extent that they can. But there are some things where we're really not going to be able to get that sort of evidence. There are programs to do with retention, rural retention and distribution, where it really is quite difficult to get to that level of analysis or assessment. So something more qualitative in that space would be, I think, highly beneficial. That's it for me.
So if I was a little bit of the devil's advocate, to do a cost effectiveness study and to look at a model of care is a pretty expensive undertaking and requires a lot of joining up, probably between a jurisdiction and the Commonwealth to do it properly. And I guess I reflect on the healthcare home as potentially one way in which the model of care was challenged with a lumped payment for diabetes. So I guess my question to the panel is, where are the funding sources likely to be in terms of doing the sorts of research that we think we need to do? And am I right that what is the balance between small pilot projects like Amanda talked about and a more big bang approach, I guess, to true workforce reform?
I think in terms of allied health, but not just allied health, there are many players out there that are very interested in improving the rural health picture, and I think they can be leveraged with good, smart, clear ideas. And I won't name names, but they're out there and they have resources. Just quickly coming back to, for example, the rural generalist theme, and for allied health, we place a lot of store on that. We think this is a vital way to go. We already have rural generalists out there everywhere. If you live and work in a rural remote community, you have to see, as an allied health person, you have to see who comes through the door. So whether you're credentialed for it or not, you are a rural generalist. We think, though, that the concept should also apply to businesses, to private practice, and just as you said, David, so that I don't think we're going to see a lot of state government lift in funding for rural and remote allied health until we can make stronger arguments of the impact of our services. But I do think that there are great opportunities to have hybrid models of allied health businesses in rural remote areas through registering for My Aged Care, for NDIS, for commissioning PHN work, sessional work with Aboriginal health services, plus treating compensable people and privately insured people who are also in the community. Once we start coming up with those models and researching them, I think that it just creates the clearest new opportunities, in our view, in the short term, if that makes sense. Does that make sense? I don't think this is impossible. I have friends who could have remained as speech therapists in private practice in Katherine had they had there was plenty of work to do, no one to pay them to do it. The need in Katherine is huge. What was missing was funding streams to support that person who was a really good quality speech therapist. Had she been there now, she could have done commissioning work with My Aged Care or NDIS, etc. We fundamentally need to reform Medicare. No one wants to talk about that in the current environment, but CDM needs to be reformed to support much more viable involvement of allied health in rural and remote areas. I won't say any more, but I think this research is not impossible or impossibly expensive.
Perhaps Amanda could comment particularly on the nursing and generalism and the future workforce.
I might make a comment about how we fund research, though. I mean, for any of you that have written a NH&MRC grant application or an ARC, they take years, huge amounts of time and huge amounts of work. I work for the La Trobe Rural Health School. I'm based in Bendigo. We've had great success with quite a simple strategy, and that is partnering with small rural health services and putting doctoral students into these communities. When you think about having a PhD student based in a community for 3 years, it costs, the health services have been funding them, by the way, and these are tiny ones that, you know, they'd say, oh, we can't afford it, the bigger ones. But, you know, when you think about it, it costs something like about $25,000 or $30,000 to have a PhD student working based in a community, doing a power of work over a 3-year period. And so, you know, that's a strategy we've been using a lot, partnering with industry, looking at what are their big questions around rural workforce, and actually sort of really doing this partnership stuff, because you get massive value. What is it, about a third or a quarter of what it would cost you for a project worker, but having a doctoral student based out in these communities, getting sort of evidence immediately to the coalface. That's been a strategy we've used really. It's much better for me to get out and talk to rural health services and try and capture what they need than spending hours and hours and weeks trying to actually work on. We heard about 1% to 2% of NH and MRC funding goes to rural, so we're using the strategy much more of how can we put my time, the team that I work with, into actually supporting doctoral students in these communities, and that's working really well. We're graduating 5 next week, so it's terrific.
Did you want to have a comment about nursing and generalism in terms of the way forward? I know this is difficult. I'm
going to make it. I can't get my head around what we mean by rural nursing generalism. I don't understand it. I'm a nurse. I'm a midwife. I've worked in small communities. I've learnt to suture. I can intubate. I can do all of that stuff. And I've had lots of people say we'll be moving to a rural generalist model in nursing. And I must admit I don't understand what that means.
Fine by me.
I would like to make one quick comment. I think one of the things that we haven't thought about in terms of the rural workforce, I'm going to make a political comment here, and that's about we don't know what the implications of the decisions around MyEFO late last year. For those of you that don't understand that, it essentially means it doesn't apply to medicine, but it applies to nursing and allied health. We now have caps back on undergraduate students. And so when we look at the workforce modelling, the predictions that have been done around nursing, we're saying by about 2030 we'll have a shortage of something like 140,000 nurses in Australia. And that decision last year, for the rural health school where I work, we increased our health students from 700 to 3,500 in a 3-year period, massive growth. And we have about 85% of our graduates working in northern rural Victoria, but we now are capped at 2017 places. We can't grow the nursing workforce at the way we currently are because we're not funded for them. No university is going to grow. So it's going to be really interesting to see what that actually does to workforce predictions. So I think we need to sort of look at, I agree, caps in some areas, but I think just this broad brush caps is going to be a problem for us, because we were looking at trying to raise rural nursing numbers by about 20% this year, and we're not doing it now because we're not funded. So,
Chris or David?
I don't know a great deal about the higher education reforms, so there's not a great deal I can say, other than I think the idea of regulating total numbers doesn't mean that governments won't be able to intervene to increase. So I don't think I've ever seen a policy setting that's been set in stone and left in stone forever before. And I think if there was evidence to suggest that we needed to increase the number of nurses in training, or evidence to increase, and that's both registered nurses, enrolled nurses, whatever the case may be, then that would be a judgment that a government would take at some stage. But obviously we'll have to wait and see what happens with the higher ed reforms as they settle in. Sorry. The question of funding of research, I'm not sure that it's an impossible ask. I think there are certainly models of care out there at the moment that are innovative, that are different, and I think a whole bunch of people in this room would be able to think of locations that they know off the top of their heads where there are people delivering high quality services that are probably having better outcomes for their patients than services that are not using those same models. I'm not sure how many UDRHs there are out there these days, but there's quite a few of those, and we have an academic workforce, we have a university research workforce in rural Australia, and I think there are some opportunities to contemplate research priorities through those organisations, and that's an ongoing source of funding and resourcing for ongoing research. and the current financing models into the system, they're changing, they're different. We're rolling out the NDIS, we're not sure what that's going to mean in terms of rural and remote workforce, but it does provide opportunities to think through things differently. Again, my aged care, and I think we provide some resourcing, certainly through PNIP for nursing models in rural areas. And beyond that, it's a Medicare rebate structure through the CDM arrangements for allied health at the moment. But there'd certainly be opportunity to look at existing models of care and whether or not there are differences in those models that are out there currently.
Just a quick comment about the rural generalist thing again, and I think I do understand some conceptual difficulties for nursing. Yeah, with allied health, we feel that if early career people, allied health professionals, go to jobs in rural remote Australia, if they do have some good quality training about the context and about extra skills they need for that context, we think that would help stabilise the workforce in those settings, and that would have a huge impact for everybody. In those terms, we would like some support. We've obviously been talking with Paul Worley and others, and we would like some support to bed that down and to evaluate that as well as we go along with that what is the impact of skilling up people in their early career for those positions. Otherwise, we have a huge turnover, huge staff turnover in those contexts because people can't hack it really without having those extra skills.
But beyond just the skills, there's also the social connectedness with the community, which doesn't seem to be sort of really well done. You see it happen from time to time where someone adopts a new professional into a community and introduces them, takes them around, looks after them, makes sure that they're not heading off to the capital city every weekend in the car or flying out as often as they can afford. But I think that's really something for communities to do. I don't think it's actually a big funding requirement, but those existing social organisations that are already out there in communities, and in many rural communities that's families, need to consider how they engage with a new professional who comes to town to say, well, look, if we want to have this kind of service provided to our children and have the kind of quality of life that's going to keep them here instead of them leaving town, then we need to embrace these young professionals who come to our community and make sure that they are socially engaged.
Anybody got any last comments? Otherwise, I might just try and sum up. So I think my conceptualisation was very much that we needed to understand who was the future rural workforce. I think the questions are, do we have enough? And that we've certainly looked, and there are probably some need for some solid longitudinal data as well as snapshot data to make sure that we are heading where we think we want to do. We've talked a little bit about what they do, and obviously that is very much the question of the moment in terms of generalism. And I think we also, and we all dance around it because it's just too hard, is how do we gauge success? And I was particularly struck by that comment about retaining people in communities, because I think we might need to reconceptualise retention. So retention is not what it was for me 25 years ago, coming to a community and you know, staying there and being there. For many of the graduates that I am dealing with, retention is 5 years, and they will have, as we keep saying, 2 or 3 careers. So I do think that if we're thinking about the research and the future health workforce, we also need to keep in mind the level of mobility of that workforce and the fact that they will probably evolve through a number of different career structures, and that if we are not flexible in the way that we apply the sorts of credentialing and arrangements around our health professionals of the future, that they may decide that they actually don't want to do it. So thank you. I'll take that as a comment. Thank you to the panel, and I think this is a discussion that should continue because, as I said, it is core business for our UDRHs, rural clinical schools, and many of our NGOs, local health districts, to get this right to the best extent that we can, because workforce is such a major component of access in rural communities. So thank you. And in fact, as was put in one of the sessions earlier, and I absolutely liked it, the more colloquial way of thinking about it is the future workforce of the future should be integrated, connected, and not solar powered. So they have to work in darkness as well as daylight. I thought that was fantastic. So how to sum up after what a hugely interesting and stimulating last 2 days? I've just got some very quick comments, and they are that I think we have demonstrated that as a sector we are more mature, and we need to thank the icons that we have walked on the shoulders of, and I now see a new generation of rural health researchers. So when I look in the room, I do not see a population of researchers and professionals that are all over the age of 50. I see a lovely spread of succession planning of people coming through. So I think we need to be really thankful and appreciative of that, and suggest that that probably suggests that we are getting much more right than we did. I think there's little doubt that the quality of the research offerings over the last 2 days has been very high, and it has come from every corner of Australia, and that UDRH and Rural Clinical School movement 20 years ago is bearing fruit, with resident rural researchers now appearing from each state and territory. There have been huge important themes about co-design with communities, and the concept of the locus of control coming back to communities, and obviously the learnings from our Aboriginal communities and our Aboriginal colleagues that this is absolutely so important. I think we are starting, and I felt over the last, and particularly this morning, that the evidence is there. The question is what we do with it. How are we going to translate the evidence that we see and the trends, some very concerning as we heard this morning, how are we going to translate those into better healthcare for our communities? I think part of that maturity is actually the appointment of Paul Worley, because surely he brings together strands of evidence and research, policy and workforce. So therein lies an opportunity, and I think we need to claim that as a very positive step, again, over the last 20 years. But you and I know that this is only a beginning, and there is so much to be done. I had a little metaphor which Janine helped me with, and that was based on Dennis's comment yesterday, which I absolutely loved, when he talked about what we really need to do is to get our research to sing. And my observation is that we're now in a choir with an accompanying orchestra, and we do have an array of different instruments. We've got rurally located researchers that need our continuing support. We have a multidisciplinary approach to rural sector workforce. We have clinicians, we have researchers, and we now have policy-informed evidence because we are having the policy people with us. And the fact that the rural workforce agencies were sponsors of this event and are with us on that journey, I think is testament to the fact that as a sector, we have the maturation to work together. So thank you for being here. Thank you for sharing that journey, and I'm sure that that journey is going to take us in a number of different and challenging directions. Thank you to the keynotes and the speakers, who I thought were fantastic. And thank you for them to keeping to time. And I know I was a tyrant, but it worked, all right? And we got that wonderful input. I need to thank the sponsors. Obviously, we've had the University of Melbourne, of Tasmania, Flinders, Central Queensland, Deakin, Griffith, Wollongong, Queensland, Southern Queensland. What an impressive list. 3 Rivers UDRH, thank you very much. And the rural workforce agencies, each of them who have come and supported, sponsored, and they've been here in numbers and in influence. We've had some fantastic exhibitors, as I mentioned, through the conference. We've had the Digital Health Agency. They got really useful feedback. They got useful feedback from paramedics and other parts of the rural health sector that they hadn't really contemplated when they were thinking of their rollout. Diabetes Australia has been heartened by some of the questions and, again, some of the perspectives that aren't on their normal radar. And we've had the Low Edge Institute, who obviously have made this huge contribution to Indigenous research, and the Mental Health Care and Practice Project, and again, some of our university partners, and the point of care testing people, the Radiometer Pacific. So we need to thank AREN, we need to thank Frame and NRHA and PCRIS for their vision in bringing this together, and it is enormously positive to sit here with an audience of the size we have, and the fact that you didn't all go home at lunchtime, which was my concern. The National Rural Health Alliance are, gluttons for punishment. So as soon as they roll away all the stuff from this, they're on the way to get ready for Hobart. Now, Hobart is a big conference, and it brings together community, it brings together arts in health, it brings together clinicians of all shapes and sizes, it involves NGOs, and it is a great place to get a real sense of the sector as a whole. Obviously, we represent policy, clinicians and researchers primarily, and training and education, but the sector as a whole will celebrate our attendance in Hobart. So please think about that, and abstracts will open in June, and we would really, really like to see you there. So I need to say a couple of really important thank yous, because this did not happen in a vacuum. I need to say a huge thank you to Leslie Fitzpatrick from AREN, who has been a tower of strength in putting this together. Thanks. Right. And Leanne and Janine from the Alliance have been amazing, as you know, and have looked after every little detail and every big detail, and to them we owe a huge debt of thanks. So please come around, Leanne, and And you want me to stop, or?
I want you to stop.
Okay, I'll stop.
I want you to stop. For the people that don't know me, my name's Mark Diamond. I'm the Chief Executive Officer of the National Rural Health Alliance. Jenny, look, on behalf of all of us, you've done a fantastic job at emceeing. Jenny was called in at the last minute, really, because Tanya, our chair, has a speaking engagement in Iceland, where she is at the moment. So it was very short notice. It was just fantastic. You managed the whole show really well from the front, and we're really proud of you.
Thank you.
Thank you very much.
Thank you, and it is my pleasure.
And look, I mean, the staff have been congratulated. Everyone back at the office, I mean, the office has been closed for 2 days. This is where they've been. And they've been working like Trojans. So, look, we're really proud to put this on in affiliation with our partners. The sponsors, as Jenny's referred to, have just been fantastic. We put out the call for interest through Leanne with invitations. We were just flooded with the universities were coming back day after day contributing. So we're just so proud of the program. And I think the attendance says it all. We had over 260 delegates here. 118 of you are Australia's lead researchers and academics in rural health. Very proud to host you. So don't forget Hobart. It's coming up, and the call for abstracts in June. Yeah. Cheers.
So finally, safe travel and avoid all the kangaroos, and we'll see you in Hobart.
With invitations, we were just flooded with the universities were coming back day after day contributing. So we're just so proud of the program, and I think the attendance says it all. We had over 260 delegates here. 118 of you are Australia's lead researchers and academics.